Hello, everyone. Am I audible? Okay. So, good evening, everyone. On behalf of NAMMA Medicine, I extend a warm welcome to all the medical students, healthcare professionals, and distinguished guests joining us today for the episode 2 of our Drips, Drops, and Disorders series. Today's session, titled From Hyponatremia to Hypernatremia, Mastering Dysnatremias, aims to provide a practical and clinically relevant approach to fluid and electrolyte disorders. We are privileged to have with us Dr. Praveenkumar Natarajan, consultant nephrologist at Tamil Nadu Government Multi-Super Speciality Hospital, whose expertise and dedication to nephrology have inspired countless learners. At NAMMA Medicine, we believe in making quality medical education accessible to everyone, and we are delighted to offer this session. We thank all the participants who have completed the pre-event questionnaire, which helps us assess baseline knowledge and tailor our academic initiatives. Following the session, we encourage everyone to complete the post-event form as well, allowing us to evaluate learning outcomes and continuously improve our programs. We hope today's discussion will encourage all of us to pause, assess, analyze, and act with precision in our clinical practice. Without further ado, I invite Dr. Praveen Kumar Natarajan to begin today's session. Thank you, and I wish everyone a fruitful learning experience.
Hi guys, am I audible?
Yes,
Are you
sir.
able to hear me? Okay, well, just give me 1 minute to set up my iPad. Today we have like two devices. I have two devices to operate with. Just give me like few seconds. I'll just set up my iPad as well.
Recording in progress.
So is the pen marking visible as well? Yes, okay. Hi guys. So really sorry for the delay. Yeah. Is the audio and my screen visible now? Okay, we'll start. Okay, cool. So yeah, today's topic was supposed to be mastering dysnatremias. So from hyponatremia to hypernatremia, but then I'm just giving a disclaimer at the start. Today we'll be just seeing about hyponatremia, because once we learn hypernatremia is like nothing basically. So hyponatremia has a lot of things. I thought this is going to be a 1 hour class, and I hope to finish it before 1 hour. But then there are lots and lots and lots of things to cover basically. So the number of slides are more than last time, but then it is going to be going like quite fast because most of them are going to be once again diagrams. So with which we'll start. So if at all you have anything to ask, you can put in the chat box. And today I'm like very well able to look at the chat box. There is no problem as well. So yes. Just brushing up what we did the last time about the sodium. So we all know sodium is a major extracellular ion. So the amount of sodium determines how much extracellular fluid should be there in the body. So it basically determines the extracellular fluid volume. Okay. So we know of the total body water, 2/3 is going to be intracellular fluid and 1/3 is going to be extracellular fluid. And in that extracellular fluid, 1/4 is going to be inside the blood vessels and 3/4 are going to be like in the interstitial space. Okay, so this is again the basics just to refresh. So to give a pictorial representation, once again, so we do have the intracellular fluid, which is the like the major part, and we have the extracellular fluid, which comprise both these. Okay, so extracellular fluid has plasma, and then we have interstitial. Okay, so this is again very, very important to learn about hyponatremia and disorders of sodium concentration. So coming to the basics of sodium regulation, okay. So one concept which we should know before we start going into the details of it is going to be the fact that anything which regards to sodium changes our blood pressure. Okay. So whenever there is increase in sodium in the body, most probably it is going to cause hypertension. Whenever there is low sodium in the body, it is going to cause hypotension. Okay. So remember, by telling like low sodium or high sodium, I don't mean the serum sodium levels. Okay. Because serum sodium level alone, I'm not telling. I'm talking about the total body sodium level. Okay. There is so much sodium in the entire body, and the total body sodium is going to be increased, the BP will increase. When the total body sodium is going to go down, the BP is going to be going down. Okay. So whenever there is change in BP, it is actually sensed by baroreceptors like right atrium, carotid sinus, and also the juxtaglomerular apparatus. So all these will sense what is the effective arterial blood volume, which is the circulating volume of blood which is present in the arterial tree. Okay. And it again sends signals to your sympathetic nervous system, your renin, angiotensin, aldosterone system, and they do produce some brain natriuretic peptides or atrial natriuretic peptides, and they also increase or decrease vasopressin levels based on the effective arterial blood volume. So the left side are the sensors and right side are the effectors. So these are the things which come into play whenever we deal with sodium balance disorders. Okay. So again, a busy slide to start with. Not to learn a lot, just remember one thing. Whenever there is hypovolemia, okay, whenever there is hypovolemia, there is activation of renin, angiotensin, aldosterone system. So whenever it is activated, we get increased angiotensin 2 and aldosterone. Both of these are concerned with salt retention. So whenever salt is retained in the body, water comes along with it. Okay, water is also retained. So we have salt and water retention. Because of this, hypovolemia will be corrected. This is the first mechanism. Second one, renal sympathetic nerves. So whenever there is activation of renal sympathetic nerves, there will be renal vasoconstriction. Again, this is more of like a DM level thing, but then just know that whenever there is renal sympathetic nerve activation, there is increased proximal tubular absorption, which also increases your sodium level. So basically, renal sympathetic activation conserves salt. That's all. Okay. So for this level, we'll just restrict to that because there is more to it, much more to it, but then we'll restrict to that. So renal sympathetic activation also conserves salt. And whenever there is inhibition of natriuretic peptides, okay, that is reduction in atrial natriuretic peptide or brain natriuretic peptide. So this again prevents sodium loss, because these natriuretic peptides cause elimination of sodium. Okay, sodium will be lost in the urine whenever these peptides are produced. So when they are reduced, it prevents sodium loss in the urine. So sodium will be conserved. Okay. And whenever there is increased ADH due to hypovolemia, so there is hypovolemia that can cause increased ADH levels also. So ADH is vasopressin, right? So whenever there is increased vasopressin, it activates aquaporin 2 channels in the kidney. So these aquaporin 2 channels are present in the collecting duct, and the main function of them is to reabsorb a lot of water. So whenever there is water which is retained, your hypovolemia will be corrected. Okay, so this is the fourth mechanism. And the fifth mechanism, I said about renin-angiotensin-aldosterone system, right? So this these things, that angiotensin 2 and aldosterone, they drive salt appetite also. They have action in the brain and they produce something called salt craving. Okay. The salt craving will make us eat a lot of salt. Whenever we eat a lot of salt, that will correct the sodium deficit. So whenever we have any sodium deficit in our body, we have activation of renin-angiotensin-aldosterone system, which causes salt and water retention and also salt craving. And there is activation of renal sympathetic nerves. Again, it helps with sodium reabsorption. We have reduction in natriuretic peptides, so they prevent sodium loss. And there is increase in ADH level, which conserves water. So these are all the mechanisms by which sodium deficit is corrected. Okay. Now, on the contrary, whenever there is excess of sodium, there is exact opposite thing which is going to happen. So there is suppression of renin-angiotensin-aldosterone system. So that will cause salt and water excretion. So they will not be conserved, but they will be excreted. And because there is less aldosterone and angiotensin 2, there is no salt craving for us. So we will not be eating a lot of salt. Okay, because we already have sodium excess. And there is decreased renal sympathetic nerve activation. So there will be increased sodium elimination. So when the system is activated, sympathetic system is activated, there will be salt conservation. When it is not activated, then salt will be lost in the urine, right? And I said in the previous scenario, there were decrease in ANP and BNP. Here, there is going to be increased ANP, atrial natriuretic peptide. So this is going to cause natriuresis. Natriuresis means loss of sodium in the urine. So we again lose the excess sodium which is present. And whenever there is sodium excess, there will be water which is retained in the body. There will be hypertension. So because of that, body senses that there is hypertension. So there is so much blood which is there. So we need not conserve a lot of water. So what it will do, it will go and reduce your antidiuretic hormone levels. So whenever antidiuretic hormones go down, then we lose a lot of water in the urine. So that is excess free water excretion. So these are all the 5 mechanisms, which is exact opposite of the previous scenario. So sodium excess or sodium deficit, they produce changes in these 5 mechanisms. Okay, we should know about this. And coming to how sodium is handled in the kidney, just look at this. So filtered load of sodium is whenever there is any filtrate which is formed in the urine, it contains most of the salt. Okay, whatever comes in, all the salt is going inside the proximal tubule. That is what you can say. So for example, if 100 molecules, okay, of sodium are filtered at the glomerulus, then 67% of them will be reabsorbed in the proximal tubule. 25% will be reabsorbed in the thick ascending limb of loop of Henle. Can anyone tell me what is the channel which is present in the thick ascending limb of loop of Henle, which reabsorbs actually 25% of the sodium? It is like a very important channel which actually helps with reabsorption and also water reabsorption. Sodium potassium 2 chloride channel, exactly. So there is NKCC2 channel, sodium potassium 2 chloride channel, which is present in the thick ascending limb of loop of Henle. So that reabsorbs a lot of salt. And also this reabsorbed salt will stay in the medulla, renal medulla. So this entire part is the renal medulla, right? So this renal medulla will be filled with salt now. Okay, so much salt will be present. Okay, which means the medulla will become hypertonic because of this particular channel, NKCC2 channel. Okay, now since the medulla is very hypertonic, just look at this loop of Henle. Loop of Henle goes in this direction. It goes up, becomes distal convoluted tubule, and then comes down as collecting duct. And you know what is the channel which is present in the collecting duct? One sodium channel and one water channel is there. Can anyone tell me what is the sodium channel and what is the water channel? in the collecting duct? So, yes, the sodium channel is called ENaC channel, epithelial sodium channel, ENaC channel. And I said the water channel is aquaporin 2. Okay. So whenever there is aquaporin 2, which is opened here, okay, in the collecting duct, water will be reabsorbed, right? This water reabsorption actually is determined by the medullary hypertonicity. And we all know this medullary hypertonicity is actually produced by this NKCC2 channel. So this NKCC2 channel is present in the thick ascending limb. It reabsorbs only salt. It doesn't reabsorb water or anything. It just reabsorbs salt, pushes it into the medulla, making the medulla very hypertonic. Okay. And this hypertonic medulla is being used by your collecting duct to reabsorb water, because collecting duct has aquaporin 2 channel. And whenever this channel is opened, since the medulla is very highly concentrated with salt, it will reabsorb water from the collecting duct. Okay. So that channel, NKCC2 channel, actually helps with water reabsorption through aquaporin 2. So this is the basic concept we should know about. Okay. And once this 25% of salt is reabsorbed in the thick ascending limb, another 5% is actually absorbed in the distal convoluted tubule, and 3% is reabsorbed in the collecting duct through the ENaC channels. And finally, the excretion is going to be just 0.4%. Okay, urinary excretion is going to be less than 1%. That's what we say. Whatever filtered, less than 1% only is going to be eliminated. So this is how complex the sodium reabsorption in the nephron is going to be. But this is again very important, because we should know about the action of each diuretic, right? We know in thick ascending loop of Henle, it is going to be the loop diuretics. In distal tubules, it is going to be what diuretics? Thiazide diuretics. And in the collecting duct, the ENaC channel, we have ENaC blockers, aldosterone blockers. We have so many things are there. Okay. So we should know about that. Okay. So this is one very favorite question which every nephrology PG, once they become nephrology PG, will be asked with. Okay. So disorders of sodium is a problem with what? That is a question they'll be asking. Everyone will be saying sodium, but it is actually not true, because disorders of sodium concentration is due to defects in water balance, right? So whenever water increases, sodium level decreases. Whenever water decreases, sodium level increases. So this is the basic concept which we should know. Everything will be like explained through images and animations. I have tried a lot to put some animations to let you know how it works. So we'll go to that soon. Okay. Now we saw about the sodium regulators, right? We studied about renin-angiotensin system, and we also studied about other things like renal sympathetic nerves, aquaporins, and all that. But coming to water, just these are very important. Okay. Whenever there is water deficit, okay, whenever there is water deficit, two things happen. Okay, one thing is going to be increase in thirst. Okay, increase in thirst, and this increase in thirst is because of all these things. Okay, increased osmolality. So whenever water decreases in the body, our blood will become very concentrated. When the blood is very concentrated, we know that the osmolality is going to be very high. Okay, so this high osmolality and water deficit, which causes hypovolemia, and this hypovolemia activates your baroreceptors. Okay, and this baroreceptors, when they are activated, they go and activate renin-angiotensin system, increases angiotensin 2. So all these will go and act in brain finally. Okay, and that will increase thirst. Okay, and all the same things, okay, same things which I told, they also go and increase your ADH level. ADH is antidiuretic hormone. So antidiuretic hormone acts on V2 receptors. V2 receptors V2 receptors are present in the, again, collecting duct cells. Okay, collecting duct cells of the nephrons, especially characters on the principal cells of the collecting duct and solo. Okay, there are V2 receptors, and this V2 receptor increases aquaporin 2 level, and this aquaporin 2 level increases water reabsorption. Okay, so this is how it works for us. Okay, so all the things which are due to water deficit, they go and activate your thirst mechanism, and they go and activate your ADH also. So whenever there is a water excess, like we drink like 20 or 30 liters of water per day, what happens is there is decreased ADH, there is increased ANP, and there is thirst suppression. So whenever there is water excess, what exactly happens? There will be hyponatremia. because blood will be dilute. Hyponatremia means decreased serum osmolality. Okay, there will be decreased serum osmolality. So this decreased serum osmolality will decrease ADH level and it causes thirst suppression. Okay, and whenever there is increased water, that will stretch atria. Okay, we have your atria, right? Whenever there is blood volume which is high, that is going to cause distension of the heart because there is huge volume which is there. So that will cause increased atrial natriuretic peptide. And this natriuretic peptide will result in natriuresis. So natriuresis means loss of sodium. I said whenever there is loss of sodium, along with sodium, we are losing something else also. That is water. Okay, so the excess water will be lost. So this is how it is going to work in the states of water excess. Again, these are all the basic mechanism which we would have come across in our MBBS times. Okay, so with which we'll go to the treatment proper, because there are a lot of other things to discuss more than, you know, this particular thing. The basics. Okay, we have a lot of clinical stuff to discuss as well. So whenever you have hyponatremia, what you should do first? Okay, a patient is coming to you, okay, with some symptoms. For example, some confusion, okay, and you are doing basic investigations and the sodium is going to be 125. Okay, so this is the sodium level. So this is the first scenario. Okay, so what you are going to do is you are going to elicit a thorough history. Okay, first thing you should know whether it is a acute problem or a chronic problem. So you should ask the patient how long the symptoms were. Okay, so because in the classification of hyponatremia which persists for less than 48 hours is called acute hyponatremia, and more than 48 hours it is going to be called chronic hyponatremia. Okay, next one, we should know about etiology, because if this patient had some history of diarrhea or vomiting, we will very well know that the sodium loss is due to diarrhea or vomiting. Okay, so based on that, we can channelize our treatment. Next important thing is the use of any drugs, especially diuretics or even laxatives. Okay, if they are continuously used, that will lead to volume depletion and sodium depletion also, that can present with hyponatremia. And other important thing is we should know about the illness of the patient. Okay, the patient can have congestive heart failure, or the patient can have cirrhosis, patient can have nephrotic syndrome, patient can have renal failure. So many things are there. All these conditions can cause hyponatremia. Okay, so all these things should be taken care of first. And the most useful test which we should do in physical examination is to assess hydration status, because everything is based on this one particular thing. So we should be very good at assessing the hydration status. Just go and check the mucosa. Okay, whether the mucosa is wet or they are dry. Dry means dehydration, that's all. And check the BP. If BP is going to be low, which means that the patient is in a state of hypovolemia, right? If the BP is going to be normal, it is going to be euvolemia. Okay, if the BP is going to be high, we definitely know it is not hypovolemia. That's all. We can't call it as hypervolemia, but then it is definitely not hypovolemia. Okay, so this is what we are trying to get from physical examination, mainly BP and checking the mucosa, right? Okay. So we all know the normal value of sodium is going to be 135 to 145 milliequivalents per liter. Okay, so this is the normal sodium values. Okay, so here I'd like to tell one particular concept for you. Okay, so this concept is measurement of serum osmolality. Okay, so you will be seeing in words. Okay, you would have seen medicine PGs calculating serum osmolality using this formula. Okay, serum osmolality is usually calculated by this formula, 2 multiplied by sodium. Okay, this is not equal to, this is plus pa. Okay, so serum osmolality is equal to twice sodium value plus glucose divided by 18 plus blood urea nitrogen divided by 2.8. Okay, so this is going to be the actual calculated serum osmolality. This is a calculation. We are not directly measuring it in the serum. We are just calculating it. Okay, for example, if the sodium is 140, okay, sodium is 140, 2 into 140 is 280. And if glucose is 100, okay, so 100 divided by 18, okay, it will be somewhere around 5, right? 100 divided by 20 is 5, so this is somewhere around 5. And blood urea nitrogen, suppose the normal is going to be 18, for example, consider as 18 for calculation's sake, okay, and 2.8, well, you can just use 3. So 18 divided by 3 is, okay, 6, right? So 280 plus 5 plus 6 is going to be 291. So 291 is the calculated serum osmolality. So in the 291 osmolality, look which is contributing the most, which is actually contributing to the most. That is your sodium level, because sodium alone is contributing 280. So the serum osmolality is majorly determined by your sodium concentration. Okay, so this is concept one. Be very clear about that. Now we know serum osmolality is determined by your sodium levels. Okay, now if you are given a case of hyponatremia, okay, if you are given a case of hyponatremia, if there is actual hyponatremia, what should be the osmolality of the serum? What will be the osmolality of the serum if there is actual hyponatremia? Will it be normal, will it be high, or will it be low? So it is going to be low. Yeah, you are telling it is going to be low. Okay, because we know serum osmolality is majorly determined by your sodium levels. If there is actual hyponatremia, then your serum osmolality should be low. Okay, so that is the concept one we should remember. So if there is a true hyponatremia, the tonicity of plasma should be low. That is, the plasma should be hypotonic. Okay, so we are not going to calculate it here now. Okay, what we are going to do is we are sending a sample to the laboratory to actually measure the serum osmolality, and how they measure serum osmolality is by a technique called freezing point depression method. Okay, using this method we will be going to calculate the serum osmolality. Okay, now I said step one is going to be history and physical examination, right? So whenever you are having a case of hyponatremia, you get a history and physical examination. Then you do serum osmolality. And what do you expect? You expect the serum osmolality to come as hypotonic serum. Okay. But what happens here is, to your surprise, it is coming as hypertonic plasma. Okay, it is coming as hypertonic plasma. You are having a sodium level of 120 only. Okay, if sodium level is 120, but you are getting your plasma tonicity as hypertonic. So what's the problem here? So ideally the plasma should be hypotonic, right? But you are getting as hypertonic. So the concept here is, which is the second concept, is called hypertonic hyponatremia. What is the meaning? Means apart from sodium, there is something else in the plasma which is increasing the tonicity of the plasma. For example, glucose. Okay. We do know the formula, right? It is glucose by 18 is also a major contributor. Is not a major, it's a minor contributor to the tonicity. For example, if we take a case of DK, diabetic ketoacidosis, sugar is going to be 600. 600 is extremely high, and the 600 will increase the plasma tonicity, right? Very simple. So that is the concept of hypertonic hyponatremia, which occurs in conditions where there is other solutes which are present in the plasma, like glucose. Okay. So you have to very carefully look at this image. Okay. So this is the extracellular compartment. Okay. This is the intracellular. We'll forget about this intracellular compartment now, because sodium, it is mostly confined to the extracellular fluid space. So these yellow dots which I have mentioned are the sodium. Okay. These yellow dots are the sodium, and this blue level is the water level. So that is the normal amount of water and sodium in your plasma. Okay. Now what happens is, you get a lot of other pink colored things. What is a lot of other pink colored things? The previous example I told, it is glucose. Okay. So there is so much glucose in the blood. Okay. Now look at the concentration of the fluid, right? The entire concentration of ECF has increased. Okay. Now the ECF has become hypertonic generally. So what happens when ECF becomes hypertonic? What happens to water level? Will the water level be same, or will it get reduced, or will it get increased? Because there is a lot of glucose in the ECF now. What will happen to the water level? Any idea? The water level is going to increase, should increase, because it absorbs a lot of water from the ICF, right? So the water level increases. Okay. Now this water level increases, and all these molecules will scatter and get distributed in the increased water level, right? Increased water level. Now the sodium is also getting scattered. Now, for your calculation sake, or just for visual representation, I'll take away all the pink things. The pink things is going to be glucose. I'll just remove that now. Now look at the sodium level. If you measure sodium level in this plasma, what will the sodium level be? what is going to be the sodium level? Yeah, it is going to be less. Why is it less? Because there is no change in the total sodium level here. Okay, there is no change in the total sodium level. Sodium level was normal, but here the problem is excess water. And because of this excess water, the sodium is going to be dilute, right? So when you measure the sodium level, it is going to be low. So this is called hypertonic hyponatremia. And why do you get hypertonic hyponatremia? Because see the previous thing. When you measure serum osmolality in this fluid, because of glucose, the serum osmolality will come as high, but actually the sodium level is going to be low. Okay, so this is the concept of hypertonic hyponatremia. Okay, all clear? If it is clear, put a thumbs up. We can go to the next one. Okay. Okay, if it is okay, put a thumbs up so that we can go to the next part. Okay, great. So that is the reason why you guys will be like learning something in your ward. Whenever there is hyperglycemia, we should calculate something called corrected sodium level. Okay, so what they say is for every 100 milligrams increase in glucose, your sodium falls by 1.6 milliequivalents per liter. Okay, for example, so in a normal condition, sodium is going to be 140, glucose is going to be 100. Okay, now if the glucose becomes 200, that is, it increases by 100, then the sodium actually falls by 1.6. So that is going to be 138.4. Okay, so do you get the concept now? Okay, but the actual sodium level is still 140 only. Okay, but it apparently looks like 138.4. So there are calculators available. You can use that calculators to calculate the corrected glucose level. So whenever you get hyperglycemia, 600 as the sugar, and then you get the sodium as 128, 129, don't think that it is hyponatremia, because if you calculate for it, it will be like either normal sodium or even high sodium. Okay, so that's what you should do at step 1. So this is hypertonic hyponatremia. Okay, so if this is clear, we'll go to the next part. Okay, next scenario. So you expected the tonicity to be low. On the first scenario, you got high tonicity. On the second scenario, you get isotonic plasma. So what is this isotonic plasma? So you measure the tonicity, and tonicity is normal. Your sodium is again 120 here. Okay, your sodium is 120. You expect the tonicity to be somewhere around 260, which is low, or 240. Okay, it should be like that. But then you get a tonicity as 285, which is almost normal, which is normal, quite normal. So this is called isotonic hyponatremia. Okay, this is called isotonic hyponatremia. This is the second scenario. So the concept here is, the third concept is, it is due to increase in non-aqueous portion of plasma. Okay, because what are the components of plasma? So this we should know. Components of plasma is water and some solids, right? What are the solids in the plasma? What are the solids in the plasma? So can you tell me what are the solids which are suspended in the plasma? Most common solid which is present in the plasma? Yeah, it is proteins. Okay, it is mainly proteins. So albumin, protein, your lipids, all these things are the solids which are suspended in the plasma. Okay, so now I'll try to pictorially represent something so that you get to understand. Okay, this is the extracellular fluid compartment. This entire rectangle is going to be your extracellular fluid compartment. Okay, and all the little things are going to be, the yellow things are going to be sodium. And what are these orange things? These orange things, these are all proteins. Okay, now this is the entire ECF compartment, but how is your blood values usually be given? Okay, in your lab reports, sodium will be given as 140 milliequivalents per liter, right? Or protein is going to be how many grams per deciliter. So they are not going to measure your entire ECF. It is given in a standardized way for either 1 liter or for 1 deciliter. That's what they give. Okay, now we'll restrict our discussion to sodium alone. Okay, so sodium is given as per liter, right? So basically, we just sample one small portion of your plasma and extrapolate it to 1 liter. Okay, now for example, think this red box is the sampled portion. Okay, This red box is the sampled portion. It has a lot of sodium and it has a lot of proteins also. We have 2 protein molecules in between. Okay. So these protein molecules are the non-aqueous portions because they are solids, right? They are solids. Okay. Aqueous portion is going to be this water. Okay. This blue color thing is going to be the aqueous portion in which your sodium is there. So in this entire box, the aqueous portion is 1 liter. Okay. And if you measure this, in that 1 liter, you are getting 140 milliequivalents of sodium. Okay. This is normal. Okay. Now consider a situation where there is excess protein. Okay. Where there is excess protein. Okay. Where will you get excess protein? Give me one example where you will get high protein levels in the body. Can you tell one example? Yeah, paraproteinemia as multiple myeloma, exactly. So this is multiple myeloma. Patient is having high level of proteins. Okay. So in the same sampled, okay, 1 liter, okay, you have a lot of proteins now. Okay. You have a lot of proteins. Now what happened to the amount of sodium in that sampled volume? Okay. In that sampled volume, which is still considered as 1 liter now, the amount of sodium is going to be coming as less. It is going to come as 112. Okay. Why is it coming as 112? This is the important concept which you should understand. In this box, okay, now is the aqueous portion really 1 liter? Is the aqueous portion, water portion, really 1 liter in the same sampled box? This yellow, this, blue color. It is not the same. Okay. Just look at the previous thing. So previous thing, you have a lot of water. Okay. In the next part, okay, the amount of water itself is going to be less. Okay. But the amount of sodium in that less water is normal. Okay. Because here it is not exactly 1 liter. Say, for example, this is actually 0.8 liters only is there now. Okay. It is going to be just 0.8 liters. Okay. In that 0.8 liters, this 112 milliequivalents of sodium is going to be normal. But then if you use older methods of, measuring sodium like this indirect ion sensitive electrode or flame photometry. So all these methods, older methods, they don't know whether this box has 1 liter of water or less water. They'll just consider this box and see how much sodium is in the box and give you a result. Now in the old methods, this box will be considered as having 1 liter of water, and in that 1 liter, 112 sodium is there. That is what the older methods used to give. But the newer methods like direct ion sensitive electrodes, okay, direct ion sensitive electrodes, they identify that within this box, there are a lot of proteins. Because of the increase in proteins, the amount of water is relatively less in this box. So they'll understand that it is only 0.8 liter of water. And in that 0.8 liter of water, we have 112 milliequivalents of sodium. So they'll correct it to 1 liter and they give the option as what will be the option? What will be the answer? It will be 112 divided by 0.8. What is 112 divided by 0.8? I'm like actually quite bad at math. I have to have a calculator to know that. Okay. So 112 divided by 0.8, that equals 140. Okay. Which is actually normal, right? So now do you understand the difference? So this is again called, this is not hypertonic part, this is isotonic. Okay, this is isotonic. Yeah. Heading on the mother. I was preparing these slides from yesterday night till today, just before the class. So just bear with me if there are some typographical errors. So isotonic hyponatremia means there is increase in plasma protein level. So the aqueous portion of plasma is going to be reduced, but the sodium level is going to be normal. But if you measure it using older methods, it is going to show a low value. But if you measure using newer methods like direct ion sensitive electrodes, it will just make up for that, loss in water, and then it will give you the correct result. So that's the concept here. That is isotonic hyponatremia. Okay. Now you get the third scenario where you get what you expect. Okay. You had a patient with hyponatremia. You did serum osmolality, and serum osmolality comes as hypotonic plasma. So this is the actual scenario when we call it as true hyponatremia, which is hypotonic hyponatremia. Okay. Puridappa. Basically, what I wanted to tell is you have to first rule out pseudo hyponatremia whenever you get a hyponatremia patient. That's all. So pseudo hyponatremia na first enna பண்ணுவீங்க hypertonic rule out பண்ணனும். So to rule out hypertonic you should do a CBG or something to check glucose level, mannitol edha போட்டுருக்காங்களா அதை we have to check. Okay, then you have to rule out isotonic hyponatremia. So isotonic hyponatremia what is the problem? You have to check serum protein level, serum triglyceride level. Okay, so இதுல ஒரு எக்ஸாம்பிள் என்ன சொல்லுவாங்கன்னா for every 1 gram per deciliter increase in serum protein level, okay, your sodium falls by 4 milliequivalents per liter. Okay, this is how much the sodium is going to fall. Okay, இதெல்லாம் ஞாபகம் வச்சுக்கோங்க. That is isotonic hyponatremia. Okay, so இது ரெண்டையுமே rule out பண்ண. You have to rule out both these. You have to rule out hypertonic and you have to rule out isotonic. Okay, those two are together called pseudo hyponatremia. Okay, once you ruled out pseudo hyponatremia, then only you should come to true hyponatremia. Okay, so now you understand that this patient whom you are faced with, that patient has true hyponatremia. Now what next? Okay, so what is this is the actual mechanism of hypotonic hyponatremia. So you are having a normal patient. I'll tell you, I have put one animation for this also. So there is one patient with ECF containing sodium. Now what happens is this sodium is lost. Okay, a lot of sodium is lost. When sodium is lost, okay, your relative concentration of sodium in the water is going to be less. Okay, so that is called hypotonic hyponatremia. Very simple concept that is. Okay, so once you are done with this, then this true hyponatremia should be classified once more. Okay, this true hyponatremia should once again be classified as 3 important types: hypovolemic, euvolemic, and hypervolemic. Because you know why I wanted to tell this tonicity before this volume status is, most of the people, even when I was a medicine PG and some of the medicine PGs now, so what they do is whenever they are faced with hyponatremia, immediately they'll go and classify them as hypovolemic, euvolemic, or hypervolemic, which actually shouldn't be done, because first you have to rule out pseudo hyponatremia. So only when you rule out pseudo hyponatremia, you have to come to true hyponatremia, and only when it is confirmed that it is true hyponatremia, then you have to classify them according to the volume status. So this volume status is hypovolemic, euvolemic, and hypervolemic hyponatremia. I'll tell you what they exactly is. Okay, now by volume, okay, by volume, hypo, hyper, or euvolemic, what do I mean? Okay, is the volume water or is it sodium? Which is very important. You know what decides the entire volume status of the body? I told at the beginning of the class, volume status is determined by your total body sodium. Okay, total body sodium. Because whenever there is more sodium, there will be more water retention. When there is more water retention, it is called hypervolemia. Right? So whenever there is less sodium, less total body sodium, that will cause water loss along with it. So that is hypovolemia. Okay, so volume status means it is total body sodium levels. That's all. Okay. Now we will go to each type of hyponatremia: hypovolemic hyponatremia, euvolemic, hypervolemic. We will see one by one. Okay, so first one I want to tell you is hypovolemic hyponatremia. So by hypovolemic, what do I mean? The total body sodium is going to be reduced, right? So consider this yellow things are the actual sodium level. Now the sodium levels are reduced. Okay, sodium is lost to a great extent. So whenever sodium is lost, what happens to the water level? I want you guys to be interactive at this point, because these are all important concepts. Once you read these concepts, you will never ever forget hyponatremia. It's like very simple. Okay, so you lost a lot of sodium, and what happens to the water? Water will also reduce. So water will also reduce. But has the water reduced all the way down? No. Okay, water is reducing, but it is not reduced to a great extent as the sodium loss. Now what happens to the remaining sodium? Okay, that remaining sodium will redistribute in the entire part. Okay, now if you go and check your sodium level in the blood, it is going to be obviously less, right? Because the sodium loss is much more than the water loss. So serum sodium appears low. Okay, any doubt with this? So this is hypovolemic hyponatremia. So when you measure, you are finding hyponatremia, and this hypovolemic is because the total body sodium is also less. That's all. So this is hypovolemic hyponatremia. Okay, we'll again brush up all these things once again. Okay, So the causes of hypovolemic hyponatremia is diarrhea, vomiting, burns, all these. We'll lose water, we'll lose salt, both will be lost. Salt will be lost more than water. Because of that, we'll be having hypovolemic hyponatremia. And these are all the renal losses. Giving diuretics, a lot of sodium will be lost. Addison's disease, there is no aldosterone levels. So when there is no aldosterone, there is no sodium retention. Because of this, there will be sodium loss. And cerebral salt wasting syndrome occurs in patients with head trauma or something, where because of head trauma, there will be increased brain natriuretic peptide. Okay, this natriuretic peptide will cause increased sodium elimination. So because of that, you will be having hypovolemic hyponatremia. Okay. So here you should understand there is loss of both sodium or water, but sodium loss is more than water loss. Okay. Yeah. With which we'll go to the next part, which is hypervolemic hyponatremia. Okay. So what do you mean by hypervolemic now? So hypervolemic means what happens to the sodium level? Increase total body sodium levels. So when there is increased total body sodium, why do you get hyponatremia? Okay, now tell me. So this is the actual image. This image has some sodium molecules. Now there are few more sodium molecules which are retained. Okay, there are increased sodium. Okay, whenever there is increased sodium and the blood becomes thick, what happens to water level? Water level also increases, right? The water level increases. But what happens here is the water level increases to so much extent than the sodium retention that your sodium, when it gets distributed throughout, okay, that will become apparently low. Even though the total sodium is going to be high, that gets distributed in the excess water, so it will be dilute. Okay, do you get the concept now? So here sodium is retained, water is also retained, but water retention is much more than the sodium retention. And because of that, you get hyponatremia. That's all. You get the concept? So if you measure serum sodium levels in the serum, it is going to be low. Okay. But the total body sodium is going to be high. So that's the concept here. Okay. So where do you get this hypervolemic hyponatremia? So where do you get hypervolemic hyponatremia? So hypervolemic hyponatremia, very classical, okay, areas where you get it is nephrotic syndrome, liver cirrhosis, congestive heart failure, and renal failure. In the 4 conditions, are very, very, very important. Okay. So basically, it is heart failure, liver failure, kidney failure. On top of that, you should remember nephrotic syndrome, which is again very important. Okay. In all these, the main culprit is going to be renin, angiotensin, aldosterone system. Okay. So that is going to cause increased sodium retention, and along with that, there is going to be increased water retention. Okay. So that's all. For example, so this congestive heart failure, in congestive heart failure, the blood volume is going to be less. When blood volume is less, that is going to cause RAS activation that will reabsorb sodium. And because of this low output and low BP, ADH will also be increased, and ADH will cause water retention. So both sodium is retained, water is retained. And the same thing in liver failure. Okay, decreased albumin production. Okay, whenever there is decreased albumin production, the oncotic pressure of the blood is going to be less. So all the water from the blood vessel is going to go inside the interstitium. So the effective blood volume is going to be less. Again, when effective blood volume is going to be less, that will increase your RAS and ADH, and same mechanism. Okay, and nephrotic syndrome also, loss of proteins. Because of that, there is a reduced oncotic pressure, and it's the same mechanism. Okay, so these are all the conditions where we get hypervolemic hyponatremia. So the problem here is you are having both water excess and sodium excess, but water excess is much more than the sodium excess. So you can write it like this. Water excess is more than sodium excess. So that is about hypervolemic hyponatremia. Okay. Now coming to euvolemic hyponatremia. This is like, again, very important. Euvolemic. What happens to the total body sodium here? I said volume status is determined by your total body sodium. So total body sodium is going to be normal. Okay. When your total body sodium is going to be normal, but when there is hyponatremia, when will it occur? When will the hyponatremia occur? So when will you get hyponatremia? So whenever there is increase in water alone, okay, should be some increase in water level. Okay, but sodium level, total body sodium should be normal. Okay, so increased water alone. So there is some condition which increases water level alone. Okay, there is slight retention of water. Because of this retention of water, your sodium gets redistributed, and then you will get a low sodium level when you sample a particular portion of plasma. Okay, so there is total body sodium which is normal. There is slight retention of water, and because of that, sodium gets diluted. So you get hyponatremia. So what is the classical condition here? Most of you have said it is SIAD, syndrome of inappropriate antidiuresis. Okay, so what happens here is there is increased ADH. This increased ADH increases aquaporin 2, that causes increased water. Pure water alone is retained. Okay, this pure water retention causes low sodium levels. That's all. Okay, it is very simple. Okay, any doubt in this? Once you grow up the ladder, you will get a lot of doubt at this point of time. Okay, so I'm just seeing if anyone gets any doubt here. If there is no doubt, then let me not confuse you. We'll go to the next part. Okay, okay, none of you have a doubt. This mannitol administration, see, mannitol is an osmotically active substance, right? If mannitol is something which stays in the blood vessel. So if you give mannitol, it is an osmotically active substance, okay, like glucose. So it will also reabsorb a lot of water from the interstitium, that's all. Because of that, there can be hyponatremia. So that's why I checked if there is mannitol administration due to some other things. Fine, okay. I think you people don't have any, yeah, finally someone has asked, why is it euvolemic if there is volume retention? Okay. See, I said euvolemia means it is total body sodium. Okay. The total body sodium is going to be normal. I said, see, there is no increase or decrease in total body sodium. So total body sodium is going to be normal. Okay. But only water is retained. Okay. So because of this water retention, your sodium gets diluted. Okay. And how long do we retain water abdina? So your body will increase ADH level. And because of that, there will be water retention. And when you retain more and more and more water, what happens is at one point of time, your BP will start to increase. Okay. When your BP starts to increase, it will be sensed by your atrial natriuretic peptide. And what will that cause? That will cause pressure natriuresis. Okay. It will try to eliminate the excess water through something called pressure natriuresis. So the amount of water which is reabsorbed by the ADH and the amount of water which is lost by the ANP will be normalized at a particular level of excess water level. So under a steady state attain iron. So normal 42, normal, for example, total body water is 60 liters, for example. Okay. If this will become 165 liters and 65 liters, it will stabilize. Okay. And because there is 5 liters of excess water, that is going to dilute your serum. That is going to dilute your total body sodium. That's all. Okay. So this is what happens in euvolemic hyponatremia. Okay. If it is okay, we'll go to the next part. Okay. Someone, Shankar Narayan, asking a lot of questions. We'll come back to all the questions at the end, because if we go back and keep doing that, we'll get the, we'll be breaking the flow of the lecture. So we'll just go to the end and then we'll come back to the problem. No problem. You can keep asking questions, and I request the moderator of this session to actually take a note of all these questions so that we can discuss at the end. Okay. Yeah. So what are the conditions where we get euvolemic hyponatremia? Only one thing which you should remember at MBBS level is going to be SIAD. Okay. And at PG level, you should know about glucocorticoid deficiency, hypothyroid, drugs, and primary polydipsia. All these should be known. Okay. But the most common thing you should remember is going to be SIADH. Okay. Fine. Okay. Now, what have we done? We had a patient with hyponatremia. So we checked the plasma tonicity. We ruled out hypertonic hyponatremia, isotonic hyponatremia, and then finally landed up with hypotonic hyponatremia, which is also called true hyponatremia. Okay. So once true hyponatremia is there, we calculate them based on, we divide them based on hypovolemic, euvolemic, or hypervolemic. Okay. That is also done. Now what happens is we have to measure urine sodium levels. Okay. When we measure urine sodium, if it is more than 20 milliequivalents, it means sodium is lost in the urine. So it is renal loss. If it is less than 20 milliequivalents, it is going to be extrarenal loss, because whenever we are vomiting or whenever we have diarrhea, It is extrarenal loss. So what the kidney does is it will try to reabsorb all the sodium to maintain the sodium level. So at that point of time in extrarenal loss, the urine sodium is going to be very less because kidney will be trying to reabsorb all the sodium. That's all. So when urine sodium is more than 20, it indicates renal sodium loss. Causes, you have cerebral salt wasting syndrome, which produces what hormone? Which produces it produces brain natriuretic peptide. Okay, brain natriuretic peptide increases salt elimination. So because of that, you will have increased urine sodium. And Addison's disease, there is loss of aldosterone. So because of that, there is no reabsorption of sodium. And thiazide diuretics block your NCC channel in the NCC, sodium chloride co-transporter in the distal convoluted tubule. Because of that, you will be having increased urine sodium. Okay, so here the kidney is losing sodium inappropriately. When it is going to be less, okay, less than 20, it can either be hypovolemic or hypervolemic. Hypovolemic causes diarrhea, vomiting, burns. All these will lose sodium and water. So your kidney will try to conserve sodium. So your urine sodium is going to be less. Okay. In hypervolemic states, like your congestive heart failure, okay, or liver failure, nephrotic syndrome, எல்லாத்துலயும் என்ன activate ஆகும்? RAS activate ஆகும். Why RAS is getting activated? Because of low effective arterial blood volume. Because of this low effective arterial, even though the entire body water is increased, all these are not within the blood vessel. Within the blood vessel, it is going to be low because congestive heart failure la cardiac output illa, nephrotic syndrome la albumin illa, liver failure also no albumin. So your blood volume is going to be less. Because of that, you get RAS. RAS means renin angiotensin aldosterone system. That will become angiotensin 2, then will become aldosterone and cause sodium retention. So when sodium is retained in the body, urine sodium is going to be less. Okay, so that's all about this. Clear? If it is clear, we'll go to the next part. This will actually help you to diagnose whether it's a renal loss or extrarenal loss. That's all. If it is okay, just put a thumbs up. We can go to the next part. Okay, cool. Just give me a moment. Okay. So now coming to the next part. Now we know whether it is hypovolemic, hypervolemic, or euvolemic hyponatremia. Once we come to this point, okay, it is actually very easy to manage basically. Okay. So the patient will come to you with either some symptoms or no symptoms. If there is no symptoms, we call it as asymptomatic hyponatremia. Okay, which is like less severe, so we can treat it leisurely. Whenever there is symptoms, you should classify whether it's mild symptom, moderate symptom, or severe symptom. Okay. Mild symptom include dizziness, weakness, vomiting, headache, all these vague symptoms. Okay, that can be treated with either sodium or with some conservative managements, which I'll tell you later. Okay, but whenever the patient has severe symptoms, we should try to correct your serum sodium levels, mainly using 3% saline, hypertonic saline. Okay, because moderate symptoms and severe symptoms irundale, it is mainly your CNS symptoms. It means that your brain is getting damaged. So because of that, you should treat the patients urgently. Okay, so just know that severe symptoms or moderate symptoms, you should give 3% saline to treat the patient. Okay, so I told in the beginning, hyponatremia, which occurs very fast, within 48 hours, we call it as acute hyponatremia. So whenever there is acute hyponatremia, you can treat fast. Okay, when there is chronic hyponatremia, you should treat slow. Okay, because chronic hyponatremia means the hyponatremia has been there for a long time. It has been there for more than 48 hours. So your brain would have adapted to this low sodium level. Okay, now if you go and try to correct this very fast, then something called osmotic demyelination syndrome can occur. Okay, I'll tell what it is exactly later. Okay, so if it is chronic hyponatremia, you treat slowly. Okay, if it is acute, you treat very fast. Similarly, if there is severe symptomatic hyponatremia, okay, whatever be the duration, acute or chronic, but if the patient has severe symptoms, then you have to treat fast. Because severe symptom means brain is already getting damaged to a great extent. So you have to treat it very fast. Okay. If it is asymptomatic hyponatremia, then you have to treat it very slow. That's all. So simple, straightforward management concepts. Okay. This slide, I'd actually ask you guys to take a screenshot of. Extremely important to know, extremely important to remember. Okay. So whenever a patient comes to you with severe symptomatic hyponatremia, whatever be the reason, whatever be the duration, okay, It can be either acute or chronic. It can be either hypervolemic, hypovolemic, euvolemic, whatever be it. If the patient has severe symptomatic hyponatremia, you have to immediately treat the patient and increase the serum sodium level by 4 to 6 milliequivalents per liter. Okay. The reason is the severe symptomatic hyponatremia usually means that the brain is actually going for cerebral edema. Okay, the brain is going for cerebral edema because your blood has a low sodium. Okay, your blood has low sodium. So blood is very thin. It contains a lot of water. Okay, your brain might not be having that low sodium. Okay, so brain will be a little bit on the concentrated part. So the water from the blood is going to go into the brain and it causes cerebral edema. So that's why there are severe symptoms in hyponatremia. So it means that the patient is having cerebral edema. So you should give measures to reduce cerebral edema. So how can you reduce cerebral edema is to correct the serum sodium levels by 4 to 6 milliequivalents. Faster we have to correct it by giving 3% saline faster. 4 to 6 milliequivalents, if the serum sodium rises, then the cerebral edema will either stabilize or it will start to settle. Okay, so that is the first take-home message. Whenever there is severe symptomatic hyponatremia, whatever be the reason, whatever be the duration, you have to immediately increase by 4 to 6 milliequivalents per liter. Okay, that's all. Okay, so that is usually done by giving a 3% saline bolus over 15 minutes. Okay, you have to give it as a bolus over 15 minutes. That's all. So any doubt with that? If there is no doubt, then we'll go to acute and chronic. Okay. So if the patient has confirmed acute hyponatremia, that is, the patient has less than 48 hours of hyponatremia, which means it has occurred very fast. So if it has occurred very fast, then you can treat it very fast. Okay. Then you can treat it very fast. So how can you treat it up now? First 24 hours, you can increase the serum sodium levels by a maximum of 10 milliequivalents. Okay. And after the first day, every next day, you can increase it by 8 milliequivalents. Okay, this is the cutoff. So first day, it is 10 milliequivalents. Subsequent days, it is by 8 milliequivalents, we can increase. Okay. If it is chronic, then you have to be very careful. I said if you are chronic, the patient's brain will be adapted to this low level of sodium. So if you try to correct it very fast and give more sodium to the blood will become very thick. Okay, the blood will become very thick, but the brain will still remain thin because it is used to this hyponatremia. So the brain is going to be very hypotonic. So brain has a lot of water, but blood has low water. So water from the brain will go into the blood and the brain will shrink. When brain shrinks, what happens? What is the condition called? What is the condition called when the brain shrinks? So do you know, it's very, very, difficult situation to handle with. So that is called osmotic demyelination syndrome. When the brain shrinks, okay, there will be demyelination, diffuse demyelination of the entire brain. Okay, there will be loss of your astrocytes and all the things will be lost due to this sudden shifts in osmotic things, and then it will cause osmotic demyelination syndrome. Okay, so we shouldn't correct chronic hyponatremia very fast. So the maximum rate is going to be in the first 24 hours, it is 4 to 8 milliequivalents, not more than that. And every subsequent day, it is going to be 4 to 6 milliequivalents monthly. So we usually say 6 milliequivalents மேல correct பண்ணக்கூடாது. Don't correct it more than 6 milliequivalents per day. How to correct the 6 milliequivalents, 8 milliequivalents is the next question. We'll see in the subsequent slides. But just know these values. These are all extremely important values. Extremely, extremely important values. Okay. So I request all of you to take a screenshot of it. Okay. So avoid overcorrection to prevent osmotic demyelination syndrome. Okay. And if it is severe symptomatic hyponatremia, give hypertonic saline as a bolus over 15 minutes and then reassess sodium every 2 to 4 hours. So this is the protocol with which we have to go ahead. Okay. Now we know how fast to correct, whether it is acute or chronic or if it is severe symptomatic, we know how to correct. Okay. Or we know how much to correct. Now we'll go about how exactly to do it in each type. Okay. Now I said if there is severe hyponatremia, you have to give 3% saline bolus. If there is moderate hyponatremia, that there is no seizure, there is no coma, nothing, then you have to still give 3% saline. I told you, right? If it is mild symptoms, you can have general measures. If it is moderate or severe, you have to go ahead with 3% saline. If it is moderate, the saline can be given as a slow infusion also. But if it is severe, you have to give it as bolus. Okay, bolus over 15 minutes. So this is how we should go about. Okay, now just to recap, we saw about the volume status, right? Volume status, like you have hypovolemia, euvolemia, and hyperolemia. Okay, so how do you find it? Abdina? In hypovolemia, the BP will be low. Okay, the BP will be low, and edema will be absent. There will be no edema. So BP will be low and edema will be absent. And euvolemic, the BP is going to be normal and there will not be any edema. The BP is going to be normal and there will not be edema. In hyperolemia, there will be edema. BP can be anything. Okay, BP can be either high or it can be low also. Because we know nephrotic syndrome. Nephrotic syndrome, edema will be there, but intravascular volume is going to be less because albumin is not there. Okay, all the albumin are gone in the urine. So the oncotic pressure is low. Because of that, blood volume is low. When blood volume is low, your BP is going to be low. Okay, so it need not always have high BP. Okay, so BP can be either way, but there will be edema which is present. So whenever there is edema which is present, we call it as hyperolemia. Again, very important. Okay, just two things you are calculating. Checking BP and seeing edema, with which you can calculate, which we can just arrive at what the exact problem is. Okay. Whenever there is edema positive, it is hyperolemia. Whenever there is edema negative, then you have to check the BP. If BP is normal, it is euvolemic. If BP is low, it is hypovolemic. That's all. Okay. So next, I'll ask you people to take a screenshot of this slide also. Extremely important, especially the second part, Andromedius formula. Okay. Right. So I told you first one day 10 milliequivalents increase panla or 20 milli or 8 milliequivalents or 6 milliequivalents, we know. Okay. Now how to do that? For example, I'll just give one example with which you understand. Okay. You are having a 50-year-old male, 70 kg weight. Okay. And he's having severe symptomatic hyponatremia. Okay. Or the sodium is going to be 115 milliequivalents. So this is just for example, just for calculation's sake. So just forget the severe symptomatic hyponatremia. You can just consider it as some severe hyponatremia. That's all. Symptoms seizure, coma, it is severe hyponatremia. That's it. Okay. So sodium is going to be 115. Okay. So if at all there is severe hyponatremia, and it is like acute hyponatremia, it is acute, less than 48 hours. So the target is going to be on day 1, it is going to be increased by 10 milliequivalents, right? So increase in 10 milliequivalents, now you should target a sodium of 125 milliequivalents. Now, how will you know what amount of fluid to give and what fluid to give? Okay, I told you whenever there is severe hyponatremia, you have to give 3% saline, right? 3% saline is the drug of choice. So step 1 is choosing the fluid. We know it is 3% saline. So we have chosen the 3% saline. That's all. Okay. Now the target sodium is 125. Okay. Now there are two formula to understand how much fluid we should give. Okay. So the first one is sodium deficit method. So what we are doing is we are going to calculate the sodium deficit in the entire body. Okay. So the formula for that is sodium deficit equals desired sodium minus actual sodium in multiplied by total body water. Okay, very important formula. Desired sodium minus actual sodium multiplied by total body water. So total body water in this person, this is a male. Male, it is going to be total body water 60% of the entire weight. So 60% of 70 kg, right? So that is 60% of 70 kg. So that is going to be 42 liter. Okay, 42 liter is your total body water, right? Any doubt with this? So 42 is going to be your total body water. So multiplied by desired sodium. What is the desired sodium? You have 125 as the desired sodium. Okay, because we are going to increase it to 125. Actual sodium is 115. Okay, so 125 minus 115 is 10. So 10 multiplied by 42 equals 420 milliequivalents. So 420 milliequivalents is the actual sodium deficit in the entire person. Okay. So when you give 420 milliequivalents of sodium, his serum sodium will increase from 115 to 125. Okay, we are not correcting it to 140. Remember, we are not correcting it to 140. We are correcting it to the desired sodium level. So desired sodium is 10 milliequivalent increase. Okay, so it is going to be 420 milliequivalents deficit. Now we have to give the patient 420 milliequivalents in one day. Okay, so that his serum sodium increases from 115 to 125. Okay, now we chose the sodium fluid as 3% saline. So we should know what is the amount of sodium which is present in 1 liter of 3% saline. So in the previous class, I told about 3% saline and all. So 3% saline contains 513 milliequivalents per liter. Okay, which is actually a little in excess of what we want. We want only 420 milliequivalents. It is 513 milliequivalents in 1 liter. So up 420 milliequivalents ki evlo liter kudukanumna calculate panningana, you will get around 820 ml. So 820 ml of 3% saline should be given over one day to increase the patient's sodium from 115 to 125. That's all. So any doubt with this? If there is no doubt, we'll proceed. This is first sodium deficit method. So one thing you should remember is this formula. Desired sodium minus actual sodium multiplied by total body water. That's all. Okay. But do we use this commonly? No, it is like very crude method. So we don't use this commonly. What we actually use is this Andromedia's formula. So what does this do? Abdina? This formula actually tells you if you give 1 liter of one particular fluid, how much serum sodium is going to increase. That is the formula which is given by this particular. That is the answer which is given by this particular formula. So I will tell you with the same example. So the formula here is change in serum sodium which will occur with any fluid is given by the fluid's sodium plus fluid's potassium minus serum sodium divided by total body water plus 1. Again, very important, especially for medicine PGs. Extremely important formula. Okay, I'll tell you with the same example. We have decided to use 3% saline. 3% saline has no potassium. It is only NaCl. It doesn't have any potassium. And the Na is going to be, sodium is going to be 513. We already know that. Okay. And serum sodium is going to be 115 in this patient. Okay. Serum sodium is 115. Total body water is 42 liters. We have already calculated. Okay. 70 multiplied by 0.6 is 42 liters. Now applying it in the formula. So infused sodium is 513. Potassium is 0. So you can just forget it. Okay, minus serum sodium. Serum sodium is going to be 115. So 513 minus 115 is 398. Divided by, it is total body water plus 1. Total body water is 42. So 42 plus 1 is 43. So 398 divided by 43, that equals to 9.3 milliequivalents. So according to this formula, if you give 1 liter of 3% saline for this patient, okay, it is going to increase your serum sodium level by 9.3. Okay, so 1 liter kudutha serum sodium level will increase by 9.3. So how much should you give? Abdina, if you calculate it, then it comes to 1.08 liters. Obviously, 1 liter kudutha 9.3. So you have to give a little more. So if you calculate, it comes as 1.08 liters. That's all. So any doubt with this? Any doubt with this? If not, we'll go ahead. Okay, so basically this second formula tells you how much serum sodium will increase if you give 1 liter of a particular fluid. So if you have to calculate it for NS, normal saline, okay, in 513 badala, you have to put 154. That's all. Okay, so if 154 put a calculate panna, how much is can someone do? How 1 liter of normal saline kudutha, how much the serum sodium is going to increase? Can someone calculate? I'll also calculate. So I got the answer. Did anyone get the answer? So did anyone get the answer? So it is just 0.9. 0.9 is what we get. Yeah, someone says 0.9 exactly. So if you give 1 liter of sodium normal saline, it will just increase the serum sodium level by 0.9. So we don't give normal saline. Okay. After 9 milliequivalents, you have to give 10 liters of fluid, which is actually impossible. So we can't give normal saline. So we are giving hypertonic saline, which is 3% saline. That's all. So any doubt? Which is the best method? Second formula is the best method. So whenever you want to do something, do it with the second formula. First formula is very crude. Okay. Second formula is much better. Okay. So someone asks how 1.08 value came, sir. So it is 10 divided by 9.3. Pi is math. Okay. No specific thing, it is max. So 1 liter kudutha 9.3 milliequivalents increase avudhu. Appo ethana liter kudutha 10 milliequivalents increase avum appadina, it is little more than 1 liter, which comes to 1.08 liter. So basically 10 divided by 9.3, that comes to 1.075 no varum. So that is 1.08. That's all. Okay. Fine. So if it is okay, I'll just remove all the annotations so that you can, just take a screenshot of that, because this slide is going to be extremely important slide. Okay. Done. Okay, great. Now we'll go to the next part. Just give me a minute. Yes. So the next part is stepwise approach to hyponatremia. So this is just again a recap of what we actually did. Okay, what we actually did. So you have a patient who is having low serum sodium level. Again, take a screenshot of this, very important. Okay, so step 1 is going to assess the plasma tonicity. So what we expect is, if it is true hyponatremia, it is going to be hypotonic. Okay, but if at all we get hypertonic, you have to rule out hyperglycemia, mannitol, or any radio contrast glycine. So all this can increase your osmolality of the serum and cause pseudo-hyponatremia. Okay, so we have to rule that out first. If we get isotonic, then you have to rule out hypertriglyceridemia, hyperlipidemia, hyperproteinemia. So all these things has to be ruled out. So if you finally get hypotonic hyponatremia, then you have to go and assess your volume status. Okay, so volume status is by what? BP and edema. That's all. So it can be hypovolemic, euvolemic, or hypervolemic. That's all. So based on this, we have to treat the patient. So how can we treat the patient? Is again very simple. Okay, I'll tell you one small hack. So hypovolemia, there is total body sodium which is lost and total body water which is lost. Which is lost more? Sodium, reduced sodium more than reduced water. So what should you give as the treatment here? So what will be the treatment here? So what is the ideal fluid to give? Okay, yeah, it is sodium rich fluid. So you have to give Na plus you have to give water. So that can be either 0.9% saline if it is mild case, or if it is severe case, you can give 3% saline. So that's all. Okay. Now euvolemic. In euvolemic, sodium is normal, but water is increased, right? So what should you reduce actually? You should reduce the water level. So how can you reduce water level? So water level can be reduced by number 1, fluid restriction. Or tell me one mechanism by which you can eliminate just pure water. Pure water can be eliminated by giving one drug. Do you know what drug it is? Vaptans, exactly. So it is vaptans. Vaptans na enna? Aquaporin antagonist illa vera edavadhu antagonist appa? It is V2 receptor antagonist. So V2 receptor antagonist. What are V2 receptors? V2 receptors தான் aquaporin increase பண்ணும். Okay, so this vaptans go and block V2 receptor so that aquaporins will be reduced. So reduced aquaporins na reduced water reabsorption. Okay, because of that, free water will be lost. That's all. Okay, simple treatment, fluid restriction. Next one is hyperolemia. Here, what is the problem? There is increased sodium. There is increased water, which is high. Increased sodium or increased water, which is high here. Increased sodium is high, right? Increased water is high. Water retention is much more. So water retention is much more than sodium retention. So what should you give? You have to eliminate water and you have to eliminate sodium. Both has to be eliminated. Okay, what is the drug of choice? Diuretics, exactly. And especially the diuretic of choice is going to be loop diuretics. Okay, loop diuretics is the treatment of choice. I think heart failure ku kudupom, cirrhosis ku kudupom, nephrotic syndrome, everything you give loop diuretics. Okay, so that's all. Easily you can remember. Okay, so this point alone you should remember this particular point, and then this particular point. So if you remember these 3 points, other things are extremely easy. Okay, so you understood now? If okay, we'll go to the next slide. Okay, great. We'll go to the next part. Okay, just a little thing about SIAD, because someone asked, no, why when there is water which is retained, but why there is no edema? So this is the problem. So in SIAD, there is excess ADH activity. Okay, when there is excess ADH activity, there is water retention. When there is more water retention, you have dilutional hyponatremia. Very simple. But this water retention causes what? ECF volume expansion. So whenever volume expansion occurs, renin and angiotensin will reduce. Okay, and aldosterone secretion will reduce. When aldosterone secretion reduces, there will be sodium which is lost in the urine. Okay, and whenever there is increased renal perfusion or whenever there is increased ECF volume, it goes and increases ANP level, atrial natriuretic peptide level. This ANP again causes natriuresis. Okay, so because of this, even though there is water retention, there is natriuresis also which occurs in some other way. Because of that, there is prevention of edema formation. So that's the reason why even there is increased water retention to some extent, we still don't get edema. That's all. Understood? If it is okay, we'll go to the next part. So this is criteria for SIAD, SIADH. Okay, this is a criteria for SIADH. Very important. So what type of hyponatremia it is? Euvolemic, hypovolemic, or hypervolemic? What is it? Euvolemic. So volume status is going to be euvolemic. Okay, that is BP is normal. Okay, what is the tonicity here? What should be the plasma tonicity? Hypotonic, hypertonic, or SIAD is a type of hypotonic. True hyponatremia vandana we will come to SIADH and all. So it is going to be hypotonicity. So plasma tonicity, serum osmolality is going to be less than 275, which is not 275 than normal. 275 to 290 is normal. So it should be less than 270 milliosmoles per liter. Okay. Urine osmolality. How will the urine be? You are reabsorbing all the water from the urine. Okay. So how will the urine be? How will the urine be? So the urine be hyperosmolar. So urine osmolality will be more than 100 milliosmol. So if the urine is concentrated, what will be the urine sodium level? Will it be less or will it be more? Urine sodium level. Urine sodium level is going to be high. So urine sodium more than 40 milliequivalents. Okay. Now, what are the other causes of SIADH? I mean, what are the other causes of euvolemic hyponatremia? You have hypothyroidism. You have hypocortisolism. So in the rendime, you have to rule out. Okay. So if you have all these, this is the diagnostic criteria for SIADH. So BP should be normal, serum osmolality should be low, urine osmolality should be high, urine sodium should be high, and you have to rule out thyroid and cortisol low states. That's all. So this is how you diagnose SIADH. So even all these criteria are, present, then you call the patient as having SIADH. Okay. Now, how do you treat people with SIADH? So what happens to the water? So how do you give water to these patients? Liberal water, no water, how much water restriction? Because we all know SIADH water restriction, but how much? Because water restriction is enough to write in your exams. But for the patients, you can't just go and tell water restriction. Okay. So what is the criteria means? Water restriction less than 800 ml per day, or okay, less than 500 ml than urine output. Okay, so this is what we say. If urine output is 1 liter, then you have to give 500 ml, or overall it is 800 ml. So less than 800 ml or urine output less than 500 ml. So two criteria. So for example, urine output itself is 500 ml, then you can't ask the patient to not drink water at all. Okay, so that is impossible. So if the urine output is pretty high, 1.5 liters, then you can go ahead with this particular thing. Okay, so this is how you restrict water. So what happens if you give normal saline? What happens if you give normal saline in this patient? Very important. Can you give normal saline to treat? Sodium for this patient is, for example, 125. Can we give normal saline to treat? Because normal saline, what's the sodium level? Normal saline sodium level is 154, right? Which is very high than the serum sodium. So logically, if you give normal saline itself, the sodium level should get corrected. But will it correct or not? Will it correct or not? Someone says hypernatremia can happen, but exactly this is the answer I actually expected, because this will not cause hypernatremia. It will further worsen the hyponatremia. Okay, because I'll tell you why. What did I tell about the urine osmolality in these patients? What about urine osmolality in these patients? High. Okay, so usually the urine osmolality will be more than 500. Usually. Okay. Means 500 per liter. So 1 liter of water, 1 liter of urine, these people can actually pass out 500 milliosmoles of solutes. What is the osmolality of sodium, normal saline? Sodium is 154, chloride is இன்னொரு 154. ரெண்டையும் சேர்த்தா it is 308. 308 is the osmolality of the normal saline. So if you give 1 liter of normal saline, you are giving 308 solutes. 308 solutes to the patient. So how much urine should this patient pass to eliminate this 308 solutes? How much? Yeah, so someone says it is 800 ml. Exactly. So in 308 300 nu vechkonga. 300 nu vechtingana, it will be like literally எப்படி சொல்லலாம், like 3/5 of the urine, total 1 liter, 3/5 of the urine, it will be lost. Okay, so 1 liter 3/5 na எவ்வளவு வரும்? It will be almost 600 ml, not even 800 ml. So 600 ml of urine, this patients will be losing all this 308 solutes. Okay, so நீங்க 1 liter கொடுக்குறேன், 1 liter கொடுத்தீங்க இல்லையா, அதுல 600 ml யூரினா போயிட்டு மீதி 600 ml லயே நீங்க கொடுத்த solutes எல்லாமே போயிடும், 308 போயிடும். மீதி 400 ml of excess fluid இருக்கு இல்லையா, that will stay in the body. Okay, and that will cause further dilution of your serum osmolality. So this 125 sodium will become 120 if you give normal saline. So normal saline is contraindicated. அவ்வளவுதான், very simple. Because urine osmolality விட நீங்க கொடுக்கிற fluid ஓட osmolality should be very high. Okay, that is what I want to tell. Okay, got it? Fine. So 3% saline, can it be given up? Yeah, 3% saline can be given because that is 513, right? 513 is the sodium level. Okay, sodium is 513. அப்போ chloride எடுத்தீங்கன்னா அது ஒரு 513. So totally it is 1026. So 1026 is the osmolality of 3% saline, but urine osmolality is just 500. So effectively you are giving more and more concentrated sodium. So this can correct your sodium level in SIADH. So 3% saline can be given, but when do you give 3% saline? When do you give 3% saline? Only when there is severe symptoms. Okay, not for all the patients, because the treatment of choice is going to be water restriction. Okay, 3% saline when they have severe. Okay, now what about the tablets? In a tablets, two kinds of tablets. Okay, you can give salt tablets. Okay, usually 1 gram salt tablets are available. 6 to 9 grams of salt you can give as salt tablets. Okay, because if you give more and more concentrated salt to this patient, these patients should eliminate these salts through urine. So they'll start producing a bit more urine and this water will be lost. Okay, so that your sodium level improves to normal. That's all. So you can give salt tablets or you can give urea tablets. So urea tablets 15 grams to 60 grams we can give per day. Because urea is a highly osmotic, it's like a concentrated salt-like thing. So if you give more urea to this patient, this urea should be lost in the urine, right? So that will pull some water along with it and go. So excess water will be lost so that the sodium level will come to normal. So these are all the treatment strategies for SIADH. So the main thing is water restriction, and then 3% saline when severe, or you can give salt tablets or urea tablets, and normal saline is going to be absolutely contraindicated. So that's all. So any doubt with this? So if at all there is any doubt, some 5 cases I have given you, we'll see how and how your logical thinking capacity is. Okay. So a 24-year-old woman presents with generalized tonic-clonic seizure after participating in a marathon. Okay, symptoms started 4 hours ago. Sodium is going to be 114. Serum osmolality is 250. So question is, what is the fluid you are going to give for this patient? What is the fluid you are going to give for this patient? Yeah, someone says it is 3% saline. Okay, excellent. So what is the target initial sodium correction? இதுக்கு சொல்லுங்க பார்க்கலாம். Yeah, someone says 120, 124, 124. No. Okay, I do get it. But the target initial sodium correction for this patient is going to be 4 to 6 immediately. Reason? This is generalized tonic-clonic seizure, which is severe symptomatic hyponatremia. So you should give 3% saline as the bolus to immediately increase your serum sodium level to 4 to 6. But 1 day correction in it. 1 day correction is going to be 10 milliequivalents. Right? So immediately it is 4 to 6. But on that 24 hours, you can increase it a little more slowly to 10. Fast or slow correction? The patient fast correction or slow correction? It is very straightforward. It is going to be fast correction. Why it is fast correction? It is going to be acute hyponatremia. It is 4 hours duration only. Okay. So it is acute hyponatremia. So if it is acute hyponatremia, it is going to be fast correction. That's all. Okay. Very good. Now we'll go to the next question. A 68-year-old man with small cell lung cancer is found to have hyponatremia during routine evaluation. Okay, this patient has mild gait instability, duration more than 2 weeks, sodium is 118. Which fluid should you give? Which fluid to be given? Someone says fluid not to be given. Excellent. I don't know who that iPhone is. Okay. Yeah, what is this condition called? What is this condition called? This condition is SIAD. Why is this SIAD? Okay, this is paraneoplastic SIAD, small cell lung carcinoma, very notorious to cause syndrome of inappropriate antidiuresis. So it is SIAD and it is a chronic condition now because it is more than 2 weeks. Okay, so it is SIAD. And since this patient is not having any big problem except for mild gait instability because he is found to have hyponatremia during routine evaluation. So we have to evaluate it. Okay, you have to go and evaluate what the problem is. But then once you evaluate and find it to be SIAD, the treatment is going to be water restriction. Okay, water restriction. And fast or slow correction, it is definitely going to be slow correction. And what is the maximum correction in 24 hours you can give in this patient? It's an elderly patient, chronic hyponatremia. So it is going to be 4 to 6. That's all. Okay, it is definitely not 10, because 10 is for acute hyponatremia where the symptoms are there. Here, this patient is having chronic hyponatremia and this patient is not having any big symptoms other than mild gait instability. So you have to correct it very slowly, just 4 to 6 milliequivalents per day. That's all. Okay. Now we will go to the next question. A 55-year-old woman presents with vomiting and diarrhea for 3 days, dry mucosa, postural hypotension, sodium is 122 and urine sodium is 10. So first, what is this? Tell me what type of hyponatremia is this? So it is hypovolemic hyponatremia. Why it is hypovolemic hyponatremia? Yeah, there is postural hypotension, dry mucosa, sodium is low, and urine sodium is less. That means urine is trying to conserve a lot of sodium. Okay, basically it is hypovolemic hyponatremia due to extrarenal loss. So what is the fluid you will give here? Exactly. So it is 0.9 NaCl, normal saline. That's all. So fluid to be given is normal saline. Okay. Fast or slow correction for this patient? Fast or slow correction for this patient? Someone says slow, someone says fast. Okay, both are correct, because initially it has to be fast because this patient is having low BP, right? Postural hypotension. So you have to give fluids, rush fluids to correct this BP alone first. Okay, once BP gets corrected, then you can slowly increase your serum sodium levels. So it is there for 3 days. So what is the level with which you can correct on the first 24 hours? First 24 hours, what is the possible? Yeah, first day it is going to be 4 to 8. On next subsequent days, it can be 4 to 6. Because it is more than 3 days, that means it is chronic hyponatremia. So on the first day, it is 4 to 8, and the next subsequent days, it is going to be 4 to 6. That's all. And the treatment is via NS. Okay, fast to correct BP alone. Because BP is always, my ABCD is always very important. Airway, breathing, circulation, kandipa very important. So first you have to correct BP. So BP correct mana, you have to give NS. That's all. Okay. Then we'll go to the next case. A 60-year-old man with decompensated heart failure presents with pedal edema and breathlessness. Sodium is 121. Raised JVP, bilateral edema. Which fluid to be given? Which fluid to be given for this patient? Yeah, someone says no, exactly. And our archeriatoda, exclamatory order put no, because that is, again, if you give fluid to this patient, doomed. That's all. So here the problem is what type of hyponatremia this is. What type of hyponatremia it is? It is hypervolemic hyponatremia. So whenever the patient has hypervolemic hyponatremia, okay, there is no role for any fluid. Okay, especially when sodium is 121 and this patient is not having any severe symptoms of hyponatremia. Okay, suppose I'm telling you one more thing. Okay, this patient is presenting with seizure. Now what will you do? And serum sodium is going to be 115. Now what will you do? So that is the beauty of correction of thing, because you know this patient has hypervolemic hyponatremia. Okay, you shouldn't give fluids. But then if the patient has severe symptoms, especially seizure, confusion, coma, anything, then you have to give 3% saline. Okay, so that's the thing here. Is hypertonic saline routinely indicated? No, it is indicated only for severe cases. Okay, only for severe cases. What is the rate of correction for this patient? What is the treatment first? What is the treatment you should give here for this patient without any symptoms? You have to give diuretics. And how much sodium should be corrected? 115 now. Okay, it is there for 5 days. 5 days. Okay. So what is it? 121 is the thing. So 121 is the value. 5 days. What is the correction rate? It is again 4 to 6. That's all. Okay. 4 to 6, 4 to 6, 4 to 6. Chronic nale 4 to 6, 6 to 4 to 6. Okay. You'll always be saved if it is 4 to 6. Okay. You have to be very careful in telling the answer as 10 because in 10 is only for acute hyponatremia. Okay. Okay. Now tell me this. A 72-year-old woman presents with confusion and recurrent falls, symptoms worsening over 1 week, sodium 108, serum osmolality 240. If you tell this correct, then I am very happy. We'll end the session. That's all, because this is the last question, obviously. So, which fluid will you give for this patient? Which fluid will you give for this patient? Which fluid are you going to give for this patient? Okay, exactly. 3% saline. Why? Why do you want to give 3% saline? Why do you want to give 3% saline? Yes, this patient has moderate symptoms. So in the recurrent falls, so confusion come under moderate symptoms. Okay. So moderate symptoms, you have to give 3% saline. Okay. You have to give 3% saline. Symptoms worsening over 1 week. So what is the treatment target here on day 1? It is chronic hyponatremia. What is the treatment target? Yeah, you can tell 4 to 6. That's all. Okay, basically on day 1, it is 4 to 8. So I don't want to confuse you more. You can stick to 4 to 6. Okay, so 4 to 6 is the immediate sodium target. So what is the maximum correction in the first 24 hours? Once again, it is 4 to 6 only. Okay, that's all. So this is how you treat. Now you know like which fluid to choose. And in the 4 to 6 FD increase pananone, you should remember that formula. What is that formula? What is that formula called? The only named formula. Yeah, it's a Madius formula. So Madius formula, you should check how much sodium will increase if you give 1 liter of either 3% saline or normal saline. So 1 liter ki increase aagum. The target is 4 to 6. So how much liters should I give? Either it can be less than 1 liter or more than 1 liter. Depends on your case. Okay, correct path you should give. It will increase. Okay. So can you repeat why it is 3% saline? Because this is symptomatic, moderate symptom hyponatremia. So for moderate symptoms and severe symptoms, you have to give 3% saline. That's all. Okay. Okay. So I think this can be a little bit overwhelming. Just think about it. If I continue with if I continue with hypernatremia, it is going to mess up your head. So I don't want to continue with hypernatremia at this point of time. We'll continue with hypernatremia in the next topic. So next topic is going to be hypernatremia, hypo and hyperkalemia. Okay, all together. Short class once again. This is again became a little bit elongated class. Okay, 1.5 hours, but then yeah. So with which we'll try to wind the session up. And there are a lot of questions. You can feel free to post it in the NAMMA Medicine group. Okay, in NAMMA Medicine WhatsApp group, you can post it so that I'll get to reply there. Okay, because I don't want to hold all you guys on the Sunday night. Okay, so please do post the questions. The moderators can gather the questions from here and then post it there so that I can answer it leisurely. Okay, so with which we'll end today's session and we'll meet. We probably might not have a class on next week, next Sunday. I mean, not Sunday alone. Maybe some other day in the weekdays. I'll try to put a session. Maybe a little late at the night. Okay, I'll just update it through the team. Thank you.
As we conclude today's session, I extend my sincere gratitude to Dr. Praveenkumar Natarajan sir for delivering such an insightful and practical discussion on dysnatremia. Your expertise, clarity, and dedication to teaching have made the session both engaging and clinically relevant, sir. A heartfelt thank you to all participants for your enthusiastic involvement and commitment to learning. Lessons and interaction have been instrumental in a successful event. We also request everyone to kindly complete the post-event Google form. Your valuable feedbacks will help us enhance the quality and impact of our future academic programs. We hope the session have provided useful clinical insights and strengthened your confidence in approaching sodium disorders in practice. Thank you again, part of drop and disorders. Have a great evening. I request everyone to kindly fill the post-event form.
I have also sent the link to the WhatsApp group. Everyone can join there for the next meeting. So thank you very much, sir. Unfortunately, Ariana could not come due to his issues. Okay, I'll end the live
Okay,
stream
guys,
and
thank you. And we'll have the next session. I'll just update you when the next session is going to be. Okay, thank you.
okay, sir. Thank you, sir. I'll end the live stream and well as